the end. I'll pull up the QR code for those in the room, but also for those online. So anyone that does it, just make sure that you do the evaluation for us so we know that we're meeting your learning needs. And then if anyone is not able to watch this live and will be watching the recording, just again, as a reminder, and I'll email this out when I send out the recording, to just let me know if they did watch it, because I'm tracking it so that at the end you can get the CEUs when we've completed the whole series. Okay.
All right. Thank you, Michelle and Flo, for having Debbie, Rekia, and myself talk about constant observation and supervised room, and also video monitoring. It's really nice to see so many friendly faces that I see at night council. So that's always a plus. ANM was actually my favorite job I've ever held in my 24 years at Northwell. I was ANM of pediatric ICU for about 7 years. And to this day, it's my favorite thing. So I can relate to all of you is what I'm trying to say. Okay, so first thing I want to explain is that this is a strategic initiative for the hospital, which means there's a lot of focus around it, not only for financial reasons, right, but also for patient safety. We want to make sure our patients are safe and we're being efficient all at the same time. So every 2 weeks, I report out on utilization of constant observation, supervised room, and video monitoring. And the way that we pull this data is through Kronos, right? That's why it's important that when we are initiating either one, supervised room or constant observation, that we're specific to our staff and colleagues as to which one we're initiating. Okay.
Code gray, 7 tower.
Video monitoring currently doesn't have its own pay code, but it's in the works, and I'm hoping within the next month or so it will. So on the top graph, I actually have to get up and look closer. This is 2022, all the way to the left, that first one. So what does that mean? This is the average number of FTEs, right? FTEs are full-time employees that we used for this period. So in 2022, we used an average of 67 FTEs for both constant observation and supervised room. So that's 67 FTEs of PCAs, right? On an average. 2023, it went up to 77. Right? Then 2024 came down a little bit to 71. And then 2025 before HelloCare, so that's before our video monitoring, which I'll show you some slides of, we came down even a little bit more to 68. So we were where we were back in 2022. And then right after that, we saw a nice dip. But now, for some reason, for the past 3 pay periods, we've seen this incline. And what we've been doing to really look at the data closer is separating constant observation from supervised room. So on the bottom graph, the dark blue is constant observation. Those are orders, right, that you need from a provider. But the supervised room has been stable at between 15 and 16 FTEs. And then with the data I collect from the flow sheets that the PCAs do for video monitoring, the little green bar on top is your video monitoring. It's not 100% accurate because it's not from Kronos. And sometimes, you know, we put a patient on, but then we don't actually document it for 15 minutes or whatever it may be. So it's not 100% accurate. But the take home is the utilization of the constant observation is on the rise. Okay, so that's something we have to be mindful for. It should really be reserved for psychiatric patients or patients that psych asked for a constant observation for, elopement risk, etc. All right. When it comes to delirium and things of that nature, or patient safety or geriatric elderly population, Deb is really going to talk to us a lot more about some strategies for reducing those constant observations. Okay. Questions? I'll pause there. And online, feel free to unmute at any time. So I wanted to show you what the HelloCare video monitoring looks like. So essentially, there's a PCA called a video monitoring tech, right? Who's sitting in 6 tower. right where the tele boxes are, right where that would be if we had downtime where the telemetry person would sit. There was some space there luckily, so that's where we are in the interim. They have 2 monitors and exactly what it looks like here. The PCA is monitoring patients virtually. Okay. They have access to a head device that they can speak to the patient through a microphone. They can hear what's going on in the room. If they click into that particular room, there's all these great capabilities. Where is it available? So all the PSP rooms. And then in the legacy spaces, it's limited to 8 tower, 9 tower. Those are our transplant areas. 2 Cohen, right, cardiac. And then 6 Monty, which is more of our general med surg. That's our where most of our hospitalist patients are. That camera right there on the right, that's what it looks like. And it's mounted on top of the TVs, essentially right there. Right on top of the TV, okay? And this is what they would see. They can zoom in, they can turn the camera to the side or the other side. Again, they can talk to the patient or they can give commands that are automated through the system, which I'll show you a little bit more. One thing that's super cool about this system, so right now the PCA is communicating to the nurses on the unit through mobile heartbeat. But if there's no time for that, there's something called a stat alarm. So the stat alarm goes off in the room. Okay, almost like an IV pump, right? But it sounds different. But it means come help quickly, right? And that sounds like this. I'm going to play it for you. And the only person that can turn it on is the PCA sitting watching. And the only person that can turn it off is the PCA sitting watching. So until somebody comes into that room, they'll continue to press that button. But here's what it sounds like. Hopefully it's loud enough.
Mhm.
So a little bit different. Oh, sorry. Okay, better? Okay. Okay, I'll stop there for a second. Any questions?
How often are those stat alarms used? Like, are they like a frequent thing?
Great question.
Yeah.
So I'm going to show you a ratio
Okay.
of how often they were able to de-escalate the patient by using a command similar to hold on, the nurse is coming,
Mhm.
or versus the stat alarm.
Okay.
Great question. Do you have a question?
Oh,
Okay. Okay.
I've heard of the PCA sit too.
So 6 tower.
Mhm.
In the interim until we find a final destination, but that's where they sit with their 2 monitors.
The old spot where the monitor.
They probably- That's what I was assuming.
And there's one on now. There's a patient on now. So if you want to walk by and just take a look at how it kind of goes, it's pretty cool. Now, what does it look like when they watch multiple patients? So this is 9 patients. If they click into the box, it increases the size of the 1 patient if they want to focus on 1 and they see that the other 8 are sleeping, right? That bottom right corner, that's like a privacy mode almost. Like there's all these things that you can do to make sure you're maintaining that patient confidentiality and things of that nature, okay? We don't need an order for this. This is completely nursing driven, nursing decision. Does my patient benefit from video monitoring? You decide when it comes off, you assess it on, you assess when it comes off. Okay, very similar to your supervised rooms. What else can I tell you here? If a patient is going off to MRI, there's a way to label that as well. So you know they're not missing, that they're, because some of these patients are on it for being elopement risks. No other reason to be on it besides you don't want them to run away. Yeah. And it works because that tech can send that nurse a message and also the stat alarm.
Motion detection?
Motion detection, not yet,
Okay.
but it is a
Got it.
capability.
Okay.
We actually were part of a work group this morning for the artificial intelligence factor of this Hello Care monitoring. So we have something called Hello Care 2, but in Hello Care 3, it does, it's able to do things like monitor for pressure ulcers. If the
Wow.
patient comes out of the bed, before the video monitor even sees it, if that ankle and foot are out of the bed, and that's how the system is set, the stat alarm goes off. So
There's that
essentially,
predictive AI capability all built in, which is nice,
Yeah.
and it integrates with Epic, so there's some other good features that will come when we upgrade, so we're.
very excited about it. Yeah, like if your Braden scores a certain number, then that would initiate, and the patient's being monitored already, of course, that would initiate your assessments, yeah.
So would that be in the form of like an alarm to bring reposition after 2 hours or something like that?
Mhm.
Okay, and then that's integrated with, I guess, Hillrom and the bed call system because they have the functionality of that too.
So they do have integration with Hillrom, but not here yet, and I'm not sure if it's gonna go to that. But yeah, it is,
Either way.
it's possible, yeah, it's very cool.
Yeah.
It's all about patient safety, really.
Renee, I just wanted to
Please,
ask,
Flo.
you know how we was talking about, communicating, it has the feature to indicate the patient's off the floor. It's essential that the nurse communicates with the video monitoring tech, that they're going off the floor. That has to get done. Sometimes team members tend to forget. And that becomes a concern because now they're like, where did the patient go or things like that. So that ongoing communication has to occur through our device, through mobile heartbeat. That's how the communication is being held between the nurse and the monitor, video monitor.
And we do have guidelines in place for who's appropriate for video monitoring, right? Your suicidal constant observation patient that psych recommended is not appropriate for video monitoring. They need somebody at the bedside, obviously. These patients need to be able to be redirected, right? If you're in a neuro ICU and you're suffering from some kind of encephalitis, and no matter what I say to you and I say, please sit down, you can't, right, comprehend, that's probably not the best patient to put on video monitoring because they physically should have somebody there if they're worried about pulling out their ventriculostomy. This is for patients, like a perfect patient was on transplant, I want to say a couple of weeks ago. He would tend to like doze off, fall asleep, and then go for his NG tube or try to get up. But then when you say, hey, Mr. Richardson, please have a seat, he would go, oh, yeah, sorry. And he actually ended up playing games with the PCA over the video. So he was good because he was redirectable. And I just wanted to show you guys how I calculate those hours with the patients. The highest amount of patients that have been monitored at once thus far at North Shore has been 5. So instead of having one PCA with each of those patients, now it puts those PCAs back on the floors with all the patients, right, being more productive than sitting with one patient. So we keep track of when they come on, when they come off, what units, why they were put on. I would say 95% of patients are put on the video monitor for fall risk. To date, and I hate saying this out loud, all our patients have remained safe utilizing the video monitor. We went live September 16th. So it's about 2 months. It's been about 2 months for legacy, but only about 1 month for the ICU spaces. That was the second phase. Another cool thing is the language. So we can redirect patients through the automated system in their language. So if it's set to Spanish, when they say, please sit down, please don't touch that, it'll say it in Spanish to the patient, which is super helpful. Because sometimes we think maybe our patients are delirious, but then when we speak to them in their language, all of a sudden you realize they're just frustrated and they don't understand us. So that's a game changer. If the PCA is talking to the patient, that doesn't get translated, obviously. Okay. Questions?
Languages. Might have to use her.
So we realized when we were a couple of weeks into the system that we were missing a lot of languages that would benefit us, so they were integrating more in. I don't know the full list, but we do have. There's a lot.
What's the proper like order for Hello Care? Like for like a provider to order this versus
No order.
No water needed.
No water.
like there's nothing.
It's nurse driven.
Completely your assessment.
Can they go to like, is this like any factor in if they're going to a rehab? Or no? Like, you know,
Yes, it does.
has to be off, okay.
Yes, it does. So
Good point.
it's similar to your supervised room. They would need a supervised room in Stern if they were going to Stern. Right? So if they don't need the resource, we get rid of it. Right? That's the important take home.
How does social work like
delays.
aware? Yeah.
So there is what I found out through this process. I found out a lot. There's a social worker, let's say for Stern, that visits here. And she physically goes to the rooms and visits each patient. So she knows whether they're being video monitored, supervised room, constant observation. Supervised room is not charted either. But they see that, and then if the patient is on it for the last 24 hours, they need that type of room, like say in Stern. I went to Stern a couple of weeks ago and I did ask about what do your supervised rooms look like? And it's only 8 beds. In that whole monstrosity, right, of a building, there's 8 supervised beds. And there's a PCA sitting in the center of the hallway. And then there's 2 beds, 2 beds, 2 beds, 2 beds. That's it. But to get one of those beds takes you so much longer. But on the other hand, if that's what the patient needs because they're at risk for falls, we don't want them to go to a regular bed then. Right? So you really have to use your true nurse spidey sense judgment to know what's appropriate for your patient. But to throw them on video for no reason is obviously silly too. All right. Okay. And to your question about the stat alarm. So this is a snapshot of about a week. And it tells us what redirections were used from the automated system. And 40 times the PCA pressed attention, please do not get up, right? 29 times they had to notify and escalate to a nurse at the bedside. They used, please don't touch that, attention, please stop what you're doing. I spoke with your nurse, somebody's coming, and please use your call light a little less frequently. But when you compare all that, they only used the stat alarm 26 times. So I would say, I did a calculation, I want to say like 30%, let's say, effective that the patient listened to attention, please do not get up. And a lot of the feedback from the PCAs is that the nursing staff and the PCAs on the floors, they really do frequent rounds and are in there very frequently anyway. And if they even hear them talking to them on the device, they come in. So it's a nice partnership. So this tells us that it is effective when using resources, yeah. Right. I'm going to turn it over to Debbie if you guys have no more questions. Yeah,
It's not recording.
correct.
No,
Yeah.
they're not.
So it's not, so that's important to know, right? Because you don't want to be recorded. That would probably make you uncomfortable, right? It's not part of the medical record.
Right.
It's not recorded and you could put privacy on at any time. The tech can turn it on and off and it comes in increments of 5, 10, 15, 20 minutes. But if you want it off sooner, you just have to let them know because they can hear you. But it is not recorded or part of the medical record. I have to say though, in HelloCare 3, there is a way that like if the patient falls, we can go back and find that data and pinpoint. Yeah, but it's not part of the medical record.
There's no like consent that needs to be
No.
for them to be. Okay.
And also with the HelloCare 3, with that privacy mode, it makes the person into a stick figure. So if they are trying to get out of bed with that AI capability, you can, yeah, stick figure. moving
And
in the
still
room,
might-
which was pretty cool. So I was like, oh, watching that. It was really cool to see how they like thought of doing that. So, or if you have a certain patient that, you know, you just didn't want to know that like they were, I hate to say a VIP patient, but somebody that you needed to remain, you know, private the whole time with, that's another way of, you don't have to show, it won't show their face, it's literally a stick figure.
Mhm.
That's like illuminating stick figure that shows you where they're going, so that was kind of interesting.
Yeah, it's scary.
Yeah,
When the patient, technically the admission consent covers us for this utilization. And then when we're asking the patients or family whether we can put them on, it's more of a, we have this device, we want to make sure grandpa's safe and we're going to be monitoring from here. We do not record. That's really the way. Yeah. And if anything, I do feel that it preserves dignity, right? If I was 90 years old and you put a babysitter in the room with me to make sure I don't fall down, I'd be really mad. Like, I feel like I'd take that a little. So there's, you know, and then when I talk to the PCAs, they say sometimes they're uncomfortable sitting in a room for 8 hours straight with one patient. So being with the video monitor, it's like something new, something different. They like it, right? More efficient. So all these great perks.
Carlos said, I feel Hello Care is phenomenal, we have to get used to it.
Absolutely. And we will. And I think with more capability and as we bring it to other units, hopefully soon, we'll utilize it. We'll, as long as the patients stay safe, I think everything will be okay. We'll get there.
And just one point from process wise, in the
Yeah.
Hello Care chat, if we are to initiate it on a patient, all we really have to do is mention it in the chat, correct? And then it'll be confirmed that the big one.
So the chat is for like so that we can have the staffing and make sure that you're aware that, because if you're asking for somebody to be put on at 11 a.m., if nobody else is being monitored, we have to wait till 3.
Yeah.
But if somebody's already being monitored, we could turn them on right away as soon as the nurse gives proper report to the PCA.
Cool, okay, sounds good.
Yeah.
And then the way to contact the PCA is only through a heartbeat. Okay.
Is someone on it tonight?
Yes.
Like, how do you see, like, how would we see that they're?
But they're,
Who do you know? Yeah, who do you know?
oh,
I think I've
great.
seen it somewhere.
Yeah.
Look at Flo's smile.
So if you go into, you know how like you find out for, who's the clinical impact team, dynamic roles? You just,
Cause you know, I guess, well, I can see it when I go to my contacts.
right, so
Like
you
Malik.
can literally search and look for video monitoring tech. And it would tell you who's on.
If you go to my units too, it will show you like who's assigned to your unit. So if you have.
That's where I'm on.
Right, but if you don't have anybody on, it's
Yeah.
not gonna show up, that's why. So you would look, which patient is on?
For 6 months.
It's not.
6 monthly? Mhm. So you would have to add yourself to 6 monthly, but you see how like you're searching because you're on my unit. It's 6 monthly. Just for the second, we'll pick it out.
Hi, Renata. Are you ready for me?
You can go ahead.
Okay. Hi, good evening, everybody. This is Deb Recchia. And just a little context before I get started. So when you saw Renata's slides earlier about the one-to-one observation, we had a goal of reducing the amount of SRs and constant observation with a specific population. So in January 2023, we opened a 10-bed unit on 3 Tower, and the criteria was 65 and older or dementia, early onset dementia. We did not include psych or substance use in that population. So we opened the ACE unit in January 2023 as a 10-bedded unit. And just again, to put it in context, in February, the PSP building opened, which is all private rooms. So one of the things that slide does not show is the ICU versus the floors. And of course, you know, for those of you who work in the ICUs, the layout of the older legacy ICUs versus the new PSP ICUs are totally different. So when you go to the PSP building as a patient, you get this beautiful private state-of-the-art room, but it is a whole different configuration. So for my focus today, it's really going to be to reduce the use of SR and constant observation in an acute care setting with a focus on the non-ICUs. Next slide. So reducing the use of the constant observation is essential for optimizing resource allocation. I'm not going to read this verbatim, but we all know that in healthcare, we have to be strategic with our finances, and there is not unlimited resources. So it's really important that we use comprehensive patient assessment. For those of you who are familiar with niche, we want to incorporate the 4Ms. And we have to make sure that we do an individualized assessment to identify patients who genuinely require constant observation, such as SI or uncontrolled withdrawal symptoms, versus someone who might just benefit from a more diversional environment. So the use of our BCAM tools and other tools to assess suicide risk versus delirium are very helpful. Next slide. So what we did is we had education. All the staff that was hired to the ACE unit went through various training, including de-escalation techniques. So they partnered with security and they learned how to do CMT, which was behavioral management, to handle patients exhibiting agitation or distress. I did hear the code gray just now on 7 Tower, and I'm wondering if that might be my next patient, to be honest.
The new
But
SR.
very often after anesthesia, after certain procedures, you will see patients that become suddenly delirious or agitated. And the staff on the ACE unit is trained specifically in ways to de-escalate before we go to the code gray or to the medication. Next slide. So what we did is we did a lot of research with the help of some of our geriatric hospitalists, and we did some environmental modifications. So you wanted to have safety where you modify the physical environment to enhance safety, and we wanted to make sure that there was, non-slip flooring, there was minimal clutter, and you could see on this slide that Hello 2 were the next approach, which thankfully Renata was able to implement starting in September. Next slide. So we implemented protocols. And again, constant observation should really only be used for behavioral patients that are psychotic or SI at the time. If you use a supervised room because the ACE unit does not have availability, that does not necessarily mean that someone has to remain with that patient at all times. It could mean that for a short period of time, you need to leave somebody in the room, but when the family's there, you might not have to. When the patient is sleeping, you might have to. So you have to regularly review and reassess, follow established guidelines to make sure that, what the level of observation is really required. Next slide. So to me, the key is patient and family engagement as well. Patients who see a stranger sitting at arm's length, especially when they're delirious, that isn't giving them a level of comfort. Like Renata said, it's frightening to them to have a strange person that close to them. Your family members to your patients are your best friends. That's a familiar face that knows their language, that knows their needs, knows their triggers, and knows what keeps them from getting to an escalating manner. So it's very important to partner with the families and to educate them about why we use bed alarms, why we use chair alarms. And it's also very important to let them know if they are leaving to get a cup of coffee or for the day, to let somebody know so that we can put our safety protocols back in place when the family does leave. Next slide. So it is a multidisciplinary approach. I'm sure everybody in this room right now has heard about the no pass zone, and that's really key. But managing the ACE unit, it takes a village, and we do our case manager, our nurses, our social workers, our pharmacists. They all do IDRs with me. We have a geriatric pharmacologist who does rounds. Um, we have a plan every day to see if the meds are not timed for 2 a.m. in the morning. So we have protected sleep time, and we make sure that it's age friendly, following the niche protocols, and specifically the 4M's guidelines for age friendly care. Next slide. This is my favorite slide. So using alternative strategies. Of course, we all hear about frequent rounding to check on the patients, but not a drive-by of just saying, hey, how you doing, and keep going. Really looking at what matters most to that patient, which is part of the 4Ms. The largest growing population that we have in the United States are patients that are 85 and older. They come into a hospital, their whole routine is flipped upside down. And sometimes something as simple as just putting some calming music on for them, dimming the lights, having a volunteer, just some pet therapy, or a volunteer just coming by to do some Reiki, or again, using music to calm, has worked wonders on the ACE unit. Next slide. So if you have a patient and all of a sudden they become extremely agitated, I always say find the why. Very rarely does a patient suddenly become agitated without a reason. If they just had a hip repair, an ORIF, are they in pain? Is it from the anesthesia? Are they urinating? Very often, when we stop to look at the why, we find out there's urinary retention involved. Maybe they have a UTI we didn't realize. Maybe they're just frightened, or they need to be reoriented. But if you get to the root cause, and pain is very common, patients that have dementia and delirium don't always say something hurts them, but you can see through changes in grimacing and um, using the FLAC score, whether or not they might have some pain. And always remember that my population, as I said, is primarily 65 and older, but usually even 85 and older, and they're being cared for very often by their spouse, who's about the same age. So I'm very focused on caregiver support. And on the ACE unit, we do partner with the Alzheimer's Association, and we have seminars several times a year, and we have a lot of information, because we have to make sure that the caregiver is able to care for that patient, so that when we focus on discharge, we make sure they go to the right environment. Next slide. So some of the strategies we use to DC COs, no one gets restrained on the ACE unit, and I prioritize the COs that are older adults to take over when I have a bed. So here are two case studies that I had jotted down. So we had an 88-year-old female. She was admitted, status post-fall, with a hip fracture, transferred from another inpatient unit. She was ordered for a CO for increased agitation, pulling at tubes and lines. Upon arrival to the ACE unit, we DC'd that, and it was determined that the patient was in pain, as I said earlier. And we always start with Tylenol first, because we don't want to over medicate our older adults. We then put her in one of our 4-bedded rooms. So if you ever visit the ACE unit, we have 2 4-bedded rooms, one female and one male. So that's 8 beds. And then the 7 remaining beds are private rooms. This patient was able to have her fear reduced by being in the 4-bedded room, and also her pain and anxiety were reduced, and she was able to leave to SAR 3 days later. The second case was a 92-year-old gentleman who was recovering from COVID. So we do not have isolation patients on the ACE unit for obvious reasons. Very often, we take our patients out into a day room common area, and we wouldn't want them spreading infection, so we don't take isolation patients. But after the infectious period was over, we transferred the patient to the ACE unit. Again, the CO was discontinued, and we engaged the patient in various activities, art, music. We have dominoes, we have bingo, we have slot machines, we have age-friendly puzzles and games. And, we wound up being able to discharge that patient back to his assisted living. And we did not have to give any PRNs for agitation. He did have to go to a higher level of care. So the assisted livings have regular areas, and then they have what's called a memory care unit. And if a patient requires that, then we work really hard to make sure they're right in the safest environment on discharge, rather than rush to get them out, and then they wind up falling. Next slide. So the takeaway is, by implementing these strategies, healthcare facilities can effectively reduce the reliance on constant observation and supervised rooms, while maintaining patient safety and enhancing the overall quality of care. Um, that cartoon might look funny, but we have had dance parties on the ACE unit. We have had a lot of things that would surprise you. Anybody who would like to walk over during the day, of course, to see some of the things that we are able to do on the unit, please come by. And one of, I think, our big successes is that Renata and I do something called CO rounds a few times a week. 4Monty and 3D have 4Monty has a 4-bedded room, and 3D has a 3-bedded room. So what we did at 1 week is a PCA swap, and I sent my PCAs there, and they brought their PCAs over to the ACE unit, so people could see a different way of caring for patients. This is a unique care model. I'm not aware of any other Northwell hospital that has this care model, and I really do believe it gives our older adults a more dignified care. And it, just to put it in perspective, when I was on the 10-bedded unit, it was a newer care model on 3 Tower, and I had hired all new staff that were right out of school. And we did have a rough year with 20 falls. This year, we went up to 15 patients, and we only had 5 falls. So I often hear people say, well, we don't want our patient to fall. Of course not. But there are ways to manage these patients and keep them safe. And that's really it. If there are any questions, I would love to answer them.
I know for niche, like, I think if your unit has a certain amount of, a percentage of, oh my gosh, patients that are 65 and older, that we've been having our nurses do complete niche and PCAs. Do you guys have access to seeing like our percentage in the hospital, or is it just based on like what the managers tell you?
So Mary Kate has access to that, and my Elena, who's retiring Friday, has access to that. I will be taking Elena's niche responsibilities over. So I'm pretty sure we can find that out.
Yeah,
I can
Deb,
only tell you that was a requirement for my hires. Everybody who was hired for the S unit had to become a GRN or a GPCA, and I now have a few nurses that are certified as well.
yeah.
Oh, nice.
So I'll just add to that. It's Michelle, for those online. So yes, Flo and I also have access to that, and all new hires have been getting it. We started that in August. So we're automatically built it into orientation. So to help you all with the percentages, that's been going since August. We can run reports. There are ways to do that. So we have access to that too, but that's been underway just to try to help increase the
Just
numbers.
to comment on that, it takes at least a full day to complete that.
Correct.
There's about 14 modules. So each
Yep.
one of my staff members did get an education day to complete those modules, with
Yep.
the expectation that they would bring the certificate in with them after that education day, which they did. And we have like a niche wall of fame on the unit with everybody's certificate.
As far as those certifications go, are we supposed to maintain like a unit binder with like all of those certificates, or do they get put in their personnel files? Or is it both?
I'm putting it in your file.
It could go into their files. It should just go into their.
Just straight into their
Yeah.
file?
Yeah.
Okay.
Yep. You could just go into their competency section, because then and then annually, it's like, they only need 6. They don't need as much as what it is when you
Oh,
first
initial.
do it initially.
Oh, so
but
there's like an
Oh, they
annual.
have to do it.
There is an annual requirement, yes, of
Can
6.
that get, is that something that they have to do through that niche platform?
Supposed to, but you can do other platforms that, like, if there's something that you could find in Cornerstone that offer, again, it has to have the CEU component, because that's where they're coming
Okay,
up
I was
with
gonna
the
say, so
answers.
we like roll it into Cornerstone,
Yeah,
so we can like
see it.
reassign it.
Exactly, so there'll be more to come with that, because there's some more digging out, and we really need to make a spreadsheet. You guys need to be able to see it, know your percentages. To your point, it's, if you don't have access to it, then how's that helping anybody? So we're trying to build something that can provide you that. So more to come with that. Any other questions for Deb? No, okay.
Or Renee.
Or Renee, yeah. Anybody have any other questions, maybe unrelated to that? You can feel free while we're here to ask, any other questions that you might have.
I have a question. I've